All right, so the time is now 9:03. We'll be starting our talk for tonight. So the topic of tonight's ANSARA Muda Career Talk Master Series is plastic surgery. So our special guest for tonight is Professor Dr. Arman Zaharil Saad from batch SPM 1992. Professor Arman, he specializes in plastic and reconstructive surgery, uh, where he is a consultant at MSU Medical Center. Now, a little background on Prof. Arman is that his first option was not actually medicine. His first option after SPM was to be a pilot. And later on, uh, he did get an interview to be a pilot, but then there was also another program, which was to do a direct fly program with Mara to do medicine. So he did this program in Dublin, which he has a very interesting story to share with you all. So in Dublin, he stayed for 16 years, where of course you could accumulate that within it, he worked there as well. So that is very interesting. So when he went to Dublin, he did the foundations. For 1.5 years, the foundations is called Irish Leaving Certificate. Supposedly, it is similar to UPU in Malaysia. And after doing the leaving cert, he went to Trinity College Dublin to do his medicine. After that, he specialized in plastic surgery, where he did half in Dublin and the other half in USM, where he worked at later. But now he works, you could just like switch the letters and it would be MSU, where he's working now. So without further ado, I welcome Dr. Arman to the stage.
Assalamualaikum warahmatullahi wabarakatuh. Thank you, Iman, for the kind introduction. Okay, let me share the screen first. Okay, thank you again for the invitation for me to give the talk tonight. Can you hear me? Okay, right. So, career talk tonight is about plastic surgery. Now, when we say plastic surgery, a lot of people, have a different idea. Most people will think it's all about cosmetic surgery. When we say about plastic surgery, they say about, okay, all the Hollywood actresses, Bollywood or artists, and Botox injection, fillers, eyelid surgery, nose job, tummy tucks, and etc. But in reality, the plastic surgery is much bigger than that. The term plastic surgery first came from the Greek word plastikos, which means the art of modeling or sculpting or to molding something. And in reality, okay, plastic surgery involves a lot of subdivision or branches of it, which cover from head to toes, okay? And there will be more than 8 subdivision or branches, and where the cosmetic surgery is only one of it. And to give you a glance through the division or the branches, which include reconstructive microsurgery, which I'm doing the subspecialties, having the subspecialties in it. And then you also have cleft and craniofacial surgery, head and neck surgery, facial trauma, fractures, hand surgery, burns, wounds, and scar management. And the list goes on, as you can see on the screen, which I will go on later to show you some of the example of the cases. Okay, back to the history. Plastic surgery is not a new thing. As you can see, the Indians' history with Sustrata Shamita, which is more than 3,500 years ago. And then you can see the Egyptians, ancient Egyptian, which was documented in the Edwin Smith papyrus, which dated about 300 thousand years ago, and one of the earliest still is come from from the Islamic community, which is from the Turkish Sarafuddin Sabunkolu, more than 400 years ago, which is documented by the book called Imperial Surgery. And then recently, not so recent, about a century ago, Sir Harald Gillis, which is also called the father of the modern plastic surgery, where he thrived in the World War I, where he treated a lot of World War casualties, for example, from the burns, from the explosion, or from the gunshot wound. Okay, so if we see the medical specialties, you can briefly, or you can roughly divide it into a surgical base, or medical base, laboratory base, psychiatry, and a general practitioner. Okay, for example, in the surgical base, you can have orthopedic, general surgery, plastic surgery, neurosurgery, ENT, and so on. And for the medical base, you have physician, cardiologist, endocrinologist, and others. And for the laboratory base, where the work is mainly in the lab, such as microbiology, pathology, and then for others group like psychiatrists and general practitioner. Then, okay, why do I pick plastic surgery? If you go back, you see there's a lot of choices in the medical specialties. So when I was in Dublin, okay, during my medical school, I was in the Trinity College. This is one of the oldest university in Europe. Okay, and during my attachment in St. James's Hospital, which is the center of plastic surgery in Ireland, I seen them doing a lot of reconstructive work in the hospital, which gave me a lot of interest because they can build something to cover defective parts or organ in the body. Okay, that's how I first have interest in plastic surgery, not because of the cosmetic part of it. So that's why now I become the reconstructive microsurgery, which is one of the branch of the plastic surgery. Now, how to get into the plastic surgery? So of course, you have to complete your medical school, okay, to obtain your MD or MB, MPCH or whatever that give you a recognized medical degree. Then you need to work in a surgical subspecialties or surgical general surgery for a while to get familiar with the surgical field, because in plastic surgery you normally work with a lot of other subspecialties. For example, ENT for head and neck reconstruction, orthopedic for the limb reconstructions, general surgery for abdominal reconstruction, cardiothoracic for the chest reconstruction, and so on. So you're not working alone basically in most part of it if you are involving in the reconstructive surgery, but you normally collaborating with others to reconstruct whatever they have to do. For example, in the tumor or cancer surgery, or in the trauma where patient missing part of the tissue or organ, limbs, yeah. So you need to collaborate with the respective specialties. So how do you want to pursue this career in plastic surgery? So you can either pick a local program or overseas program. So basically in Malaysia, we are recognizing the UK type of program and also from our neighboring countries. But the US system is still not fully recognized in Malaysia. Okay, so for example, in the UK system, you have you need to go into basic surgical skill training first program, and then you go to the higher surgical training or HST. So which will give you a title of a fellow in Royal College of Surgeons. Okay, in Malaysia, The structured program only provided by USM or in Kota Baru by through the master program. Okay, this is a 4-year program, and you need to have a certain experience in the surgical field before you can apply to the program. I will talk about it later. And another way is based on the apprenticeship. This is basically done in the several Ministry of Health hospital or KKM hospital, and this is less structured, but now they have combined it with some overseas pre-qualification such as the AFRCS as an entry point. So you need to take that exam before you can apply to become the apprenticeship in this in the plastic surgery fraternity. Okay. Now, for master's program, which is only offered in USM at the moment, which is based in the health campus in Kubang Krian, Kelantan. So the basic requirement is as I said before, you need at least to have a medical degree first. You need to complete your housemanship, and you need a basic surgical rotation. This one you need to apply when you finish your housemanship. You need to talk to your surgical, get know your surgical team or surgical head of service, so that they can place you in the appropriate attachment or rotation before you can apply for plastic surgery master program. So the minimum requirement is an 18-month in general surgery, okay, and 6 months in any other specialties such as ENT, orthopedic, cardiothoracics, and so on. So once you have a 2 years experience in surgical rotation, then you can only apply for to get into the master program. So for me, I done more than 2 years, okay, and I do a lot of subspecialty rotations such as ENT, orthopedics, what else? Pediatric surgery, maxillofacial, and I also do a plastic surgery as part of the 6-month rotation. This will give you more experience when you co-manage or collaborate with other subspecialties when you become the specialist in the plastic surgery. Okay, so how do you get in? So once you complete the requirement, the basic requirement, the pre-entry, nowadays the KKM has made it, or Ministry of Health has made it compulsory for the candidate to sit for a centralized entry exam. This is mean for them to assess who will be entitled to get the scholarship or HLT. Okay, and then once you pass your entry exam, if you are fulfill the requirement by the KKM, you'll be called for the interview. And if you have certain things in the with you during the interview, such as interest in research, you have a journal paper publications, or presentation or attending conferences in the plastic surgical conferences, maybe you have a higher point in getting to the master's program, because the competition is very stiff. So every year we got about 20 people shortlisted for the interview, and only 5 to 10 places were offered regularly. But now I think because of the what they call it, the KKM already make it very strict, so less number of candidate will be offered by them. Another way, if you're not from the Ministry of Health or KKM, maybe you can join the university such as a UKM, a UM, UPM, or other universities in Malaysia, and this university have a special seat in the training program as a collaboration with the University Science Malaysia. So you have better chances to get in earlier if you are in the university, because normally the university candidate, they are very what do you call that, focus. When they join in, they already know they want to join in as a plastic surgery, for example, or they want to join as ENT surgeon, for example. So they will be sent to enter to this program quicker than if you are in the Ministry of Health hospital. Okay. Now, I already mentioned some of the division in plastic surgery and up to wound and scar management. Then you also have a skin and soft tissue malignancy or cancer. You can have vascular malformation or deformities, and vascular access surgery. I think this is for minor vascular surgery, for hemodialysis preparations, perineal reconstruction, lymphedema, cosmetic surgery. Actually, the list is not limited to this, but there is a more subdivision in the plastic surgery, such as laser, skin graft surgery, and so on. Okay, just to give you some picture or example of the cases. Okay, in reconstructive microsurgery first, because this is my special interest. So what is the reconstructive microsurgery? This is a transfer of a tissue from one part of the body to reconstruct a missing or defective part at another place, which require reconnection of its blood supply, for example, artery and vein usually, and maybe you can add the nerve to make it sensate or functional. So for example, you see in these photos, so bone and the skin were taken with its blood supply. So this is, you can see, the blood supply to the bone here, and also this is the blood supply to the skin, which is interconnected to each other. And then this need to be joined back to the place where we want to reconstruct. For example, normally the bone that we take from the leg here, what we call fibula, is used to reconstruct another bony defect, such as in tibia or femur, or radius in the hand, or even in the jaw or mandible reconstructions. Yeah. And then this one, the transfer of muscle. Okay, this muscle taken from the inner thigh and connect back in the face for facial movement. Yeah, this patient has born with a congenital defective facial muscle, so he cannot move one side of the face. So with this reconstruction, and she will obtain the movement of the face after the reconstruction is successful. Now, patient with a cancer, skin cancer that eroded into the cheekbone, to the eye, and also into the jaw. So you can see this is a complete reconstruction where almost half of the face was removed, including the orbit or the eye. Okay, you can see the picture here. See the outline of the excision. And then the tissue that we can take, there's a lot of options, but in this case, I've taken tissue from the back and the side of the chest with the bone from the scapula, or we call a wing bone. Yeah, and then this is used to reconstruct the face, and this is the final outcome, as you can see. Yeah, it won't look as a normal, but it will fill up the hole and restore the function. For example, the chewing, swallowing, and also what do you call that? Relieving patient from the pain and the problem with the tumor cell or tissue, which is smelly, bleeding, and etc. Now, this another example where the tissue taken from the thigh, yeah, see, skin and fatty tissue with its blood supply to reconstruct a tongue after patient have almost all of his tongue removed because of tongue cancer. Okay, I have a lot of photos here. There's a lot of cases. If time is limited, please stop me and we can go to a Q&A or to answer any question if anybody have later. All right. So this is another example, still concentrating over the reconstructive microsurgery. This patient, she had a cancer of the left side of the cheekbone and jaw. Okay, see the cancer is so big. You can see I did a 3D printing of the skull, and you see almost, half of the mid face was affected. So again, this is the bone, if you can see, and this is skin muscle to reconstruct the face. And after removing the eye, half of the cheek, and the upper jaw. Okay. This surgery, as you can see, is quite extensive, leaving a lot of defect. And with reconstructive microsurgery, you can help patient to rebuild the area that was missing. This patient now is happy and healthy, no pain, can eat. When he came for treatment, his weight is only about 50 kilos. Now he's putting more than double of his weight when he come in, more than 100 kilos now at the moment. I just saw him a few days ago. Now, this is another advanced cases of head and neck cancer. So this is origin from the salivary glands. Okay, when the surgery was performed, we removed, I think, about maybe 2/3 of his face, yeah, including the forehead bone, the left eyes, whole of the nose, yeah, palate and everything. So this is what we see behind this, what do you call that, dressings, or maybe a tissue, what do you call, gauze, yeah, is his brain, yeah. And so we did put a bone here to give a support to his eye, and then the tissue taken from his thigh to reconstruct to fill up the defect in his face. Yeah, the nose I was planning to reconstruct later, and he just passed away short of 18 months after the surgery, which, with this type of cancer, his face actually is clear of tumor when he passed away, but he died of the secondary malignancy that affected his lung, because the tumor already spread to his lung when he came in for the surgery. But at least we give him a good quality of life, pain-free, he able to eat, speak, and spend his last moment of his life, without any pain with his family. This surgery lasts about 24 hours, and this is a team, my colleague and my assistant for the surgery. Now, other division, which is a cleft and craniofacial. Cleft meaning you can see a cleft lip and palate patient, or facial cleft. Cleft lip and palate are more common. As you can see, this is a left unilateral or one-sided cleft lip and palate. So this is immediate after the surgery. And then this is, you see, bilateral cleft lip and palates. And this is a photo after the reconstructions. Okay, this is one of the paper that I have published in the international journal, which is a study of the outcome of the cleft lip and palate following one of the technique of the cleft lip and palate repair. Okay. Now, other thing that plastic surgeon do is manage is a facial trauma. You can see, you can either have just a simple laceration or cut in the face, or you can have a complex injury such as this, where you have a degloving injuries over the periorbital around the eyes region, yeah, This one, for example, you have the lower eyelid defect and cheek. So we borrow tissue from the side of the face and back of the ear and rotate it to reconstruct the defective area. Okay, and this is the early result after the surgery when the wound has healed. Yeah. So another complex facial injuries. This is from the motorbike injury where he had run over the back of a lorry and his mid face has gone into the exhaust pipe. So he lost the mid part of his face, which include the nose, lip, and also the palate. So as you can see here, he has a hole in the mid face area. So this is after the first stage of the surgery where we close the hole and reconstruct the hard palate. And then the second stage is to reconstruct the nose. So we need a skin to create the nose, and also the soft bone or cartilages which was taken from the ribs. And then this is stage one, pre-expanding the skin. This is stage 2, where we create the nose with the from the skin that we have expanded, and also the cartilage from his rib. And then the final stage is to tidy up, to reshape it properly. Okay.
Doctor.
Now, yes.
I'm sorry. I know it's not Q&A session yet, but why do you have to like push it up before you do the other stuff?
Okay, if you can see he has a very narrow forehead and the skin is very limited. So if you see how much skin I need to take to create the nose here. Yeah.
Oh.
So if we take this much of skin from this, so he will have a big hole here also. So after the transferring the nose here, skin here to the nose, you see the defect he has in his forehead only this much, which I close later, you know. But if he has this big defect in his forehead, so it's very hard to get this type of appearance, yeah, after the nose reconstruction.
Okay. Thank you.
Now, other part that we also treated is a facial trauma or facial fractures. You can see here, there's a zygomatic arch, bone around the orbits or the eyes, and the maxilla or the mid face has fracture in the trauma. Okay, so as I give example earlier, we also treat facial asymmetry or facial palsy, which can give you a lagophthalmos, which is a failure to close the eyelid properly due to lack of the muscle power. Asymmetry, the patient can have drooling of the saliva. And then what we can offer here is eyelid surgery, and then reconstruction of the facial muscles, such as either you can use static or dynamic reconstruction. Okay, so in this case, you see the patient has unable to close the eye properly due to the weakness of the eye around the orbit. So in this case, one of the way to help patient to get a full closure is by insertion of gold weight. Yeah? So this is to show you the customized gold weight that was made and inserted into his upper eyelids to give him a full closure after the surgery. Okay. Okay, another part of the facial palsy reconstruction is to reanimate or make the face move again. Okay, so one way is to insert to transfer a muscle from a distant place, and then you can see here, and we connect the blood vessel and the nerve to make it functional. Okay, so I don't have the video here. If not, you can see the patient smiling, and then the face is moving, and also can she's able to move the lower eyelid because the muscle we can split and insert at a different or various places in the face. Okay, other division or sub specialties in plastic surgery is a hand surgery. It can be either trauma or in tumor or congenital defect. See, there's a fused hand, what we call syndactyly. Okay, you can help them to make it to separate the digit or the fingers. Patient can have extra digit or polydactyly or a complex syndactyly, such as in this case. Yeah. So stages of operation normally will be done in the complex syndactyly, not like a simple one. We can just have one surgery and separate the digits. Okay, other things that we do in the hand surgery, such as amputation. Okay, you can have a multi-level amputation, either single digit, multiple digit, in the forearm or in the arm or around the shoulder amputation. Okay, this is one of the worst case that I've managed. The patient was transferred about 6 hours from a district hospital to HUSM at that time. And then this photo was taken from one of the newspaper cutting. And you can see the patient, it's a lot of bleeding, and the hand actually under the pickup hilux that he was driving. Okay, the early stage, the hand, the arm was, the limb was replanted to his body, shoulder. And this is about, I think, 1.5 years when he started to have his function again. So able to keep his hand, limb, even though slightly shorter, and able to shake hand and do a like course function of his hand, because it's very difficult for the nerve to regenerate or recover up to the small fine-tuned function in the hand. Yeah. So in the tumor in the hands, so when you remove, you need to cover back. So this is tissue or skin taken from the thigh, and because it's a reconstructive microsurgery, you have to reconnect back all the blood supply and cover the wound. Okay, so this is another case of cancer in the bone, in the hands, yeah, around the wrist area. You can see the swelling here that involving the bone. So in this case, I think we take the fibula or the bone that I showed you earlier in the leg and reconstruct the defect. Yeah. And other minor surgery in the hand, such as carpal tunnel syndrome or trigger finger, also can be managed by a plastic surgeon who has an interest in hand surgery. This is overlap cases that also be done by orthopedic surgeon. Yeah? So other subspecialties in plastic surgery is burn surgery. As you can see, this is a child who was in the car with an exploded cylinder of gas, yeah, and then he sustained quite extensive burn. You can see in the face, body, back, yeah, and also the limbs. Yeah? So this is him after, I think, almost 2 months, yeah, in the ward, and he is, I think, lucky to survive the injury, because his injury was quite extensive. As you can see, he was put in the ICU or burn unit with what do you call it, ventilatory support, or machine that assists his breathing. Yeah. Okay, so another case of burn injury, but this time the patient coming with a post-burn contracture. Yeah? So you can see patient unable to move the neck fully. So here we release the contracture. As you can see, when you release, make a cut here. So you can see a big defect. So normally you can put the skin graft or other technique, but the contracture or the scarring will recur. So the best thing is to put a nice tissue, which I take in this case from the groin area with its blood supply, and reconnect it back to the neck vessel. Yeah, and this is early post-operative photos. Okay, other things that we also manage, such as skin cancer. This is very orbital or lower eyelid cancer. This is the ear, nose, and cheek. Mainly in the face. But if it's happened elsewhere, such as in the body or in the limb, this can be a crossover cases that also can be managed by general surgeon or orthopedic surgeon. Okay, example, in the face, you not just simply remove the tumor, but you try to reconstruct to give it a symmetry. See, if you have a defect like this, you just pull the edge to edge skin to close it, you may have a upper lip that is slightly lifted up. So in order to avoid that, as you can see, the skin can be borrowed from the nearby tissue and slide it up with its blood supply. And you can see this is early post-op, but after a while, you can hardly see the scar around the surgical site. Yeah. So this is another type of cancer that happened in the heel pad. Yeah, heel pad at the sole of the foot. So this is a malignant melanoma, one of the nastiest skin cancer with higher rate of mortality. So when the cancer was removed, so the skin from instep is elevated and transferred to the heel area because of the light to light structure. So it gives a very good reconstruction result. Yeah, where patient still have sensation and tough skin for weight bearing. Yeah. So another area, breast reconstruction, not just breast augmentation or breast reduction surgery. So breast reconstruction is performed in the patient after mastectomy, where the cancerous part of the breast has been removed. So this is a very old picture that I've brought back from Dublin. Okay, so you can see in our population, you can hardly see what they call that, a bikini shadow on the breast. Yeah, because this in Caucasian, they like go to beach, wear bikini and sunbathing, and then they will have a tanning area beyond the bikini bikini line. Yeah. So here the skin is taken from the lower abdomen, which is plentiful, especially in the patient who already has children. Yeah? After pregnancy, most people will have excess skin. So this skin normally remove, same area is removed in the tummy tuck surgery, but in this case, we preserve it and transfer it up here, reconnect the blood supply to the chest and make it a breast shape. So which is look quite symmetry and natural. The advantage in this type of reconstruction, if we compare to the implant or putting silicone, is a natural tissue, which is patient own body tissue, and normally it is with less complication, and the nipple will be reconstructed later. So moving to another part, lower limb salvage, such as in the amputation. Same like in the upper limb, when you have amputation, we can help the orthopedic replanting the limb in the leg or in the foot. This is two different cases of the ankle amputation. This is a sharp ankle amputation. This is blunt or crush injuries in the accident. This is a patient which was assaulted and was the leg was cut with a sword. Yeah? And this one is slightly different. You can see the tissue is damaged during the accident and need to be replaced after the replantation. Okay, this is a vascular access surgery normally performed in the end-stage renal failure because it's involved vascular surgery or microsurgery in some patients. So that's why some plastic surgeon like me can do this surgery. And this is an overlap cases that can also be done by the vascular surgeon. So managing a complication of vascular access surgery where the patient had a infections or aneurysm where the blood vessel become swollen and ruptured, so we can repair it again and close it. Okay. Another surgery or type surgery can be performed by plastic surgeon is by doing a skin graft to cover wound from different various area. So if a split thickness skin graft can give you a bigger area of skin to be used for skin reconstruction. Okay, and for this one, you see this is a skin from a skin bank, or we call allograft, that can be used temporarily to manage patient with a burn surgery or usually with extensive burn surgery where the patient have original skin has been reduced in area because of extensive burn. So the graft can be used, the allograft or skin bank, skin from the skin bank can be used as a temporary measure until the healing takes place. Okay, elephantiasis or lymphedema, or in Malay called kaki gajah or untut. Okay, this is a debilitating condition where the patient have a massively swollen lower limb, which impair their functionality, their appearance, yeah, their movements, and this. In these cases, there's a few options available for them, depend on what stage they are presenting. If they present in early stages, like this lymphatico-venous anesmosis can be performed, and with this it helps to drain the lymphatic fluid from the limb into the vein in the sort of bypass mode. So the fluid from the limb can be easily channeled back to the blood circulation system with the aid of a compression garment or stocking. So this is one of the example. When the patient came with a late stage or final stage, stage 3 of a lymphedema, it's very hard to make it reversible because there's a lot of fibrosis inside the tissue. So what can be done is totally remove the tissue and skin graft the remaining area, so the patient can have a better appearance and also functionality. And this patient back to riding motorcycle again after the surgery. He can able to walk and he's very happy man. Now, other specialties or subspecialties in plastic surgery is managing wound. This is because with our expertise, we can transfer tissue or we can do a skin grafting to cover the wound. So wound is one of the subspecialty in plastic surgery, where we normally manage a complex wound. Simple wound, most clinician or physician or surgeon should be able to manage themselves. For example, so this is a quite complex wound where the patient had a diabetic foot with a large wound over the ankle area and the joint are exposed. In this area, you can have a patient has again diabetic foot with exposed bone and soft fascia, which is hard to heal. And then this is a complication of a heart bypass surgery where the chest or mediastinum is exposed. And this is a complication of diabetic where the patient has a large wound over the back following the infection. So some other example of the wounds in the leg. And diabetic foot is always difficult. You can see patient end up with Okay, sorry, this is in the hand. Yeah, patient end up with amputation of the middle 3 digits and leaving the thumb and the little finger remaining. And this is the lower limb or leg, the diabetic foot. And again, this is also diabetic foot where you can have the Achilles tendon exposed. And this is very difficult to heal if not being assisted with a tissue transfer or skin graft and special type of dressing that can be offered in this type of patient. Okay, I think there's a lot of review of what plastic surgery is. So if you want to keep following me, you can, there's 3 options. Okay, you can follow me via the Instagram or Facebook or my Twitter. I think nowadays is quite busy for me, and I maybe update the interesting cases or the cases that I do in once in a while. But you can see the previous one in this media social network that I listed here. All right, with that, thank you for your attention. And if there's any question, feel free to ask. If I can answer, I will try my best to give you all the information or whatever I can. All right.
All right. Thank you so much, Dr. Arman. It was very detailed. Like there were so many subs in plastic surgery in itself. And obviously, I think this is enough evidence to many of us who are watching that plastic surgery is more than cosmetic surgery that we always hear about. All right. Okay. So while we wait for questions to come in from FB Live through ANSARA Muda page and also from Zoom itself in the chat box, I would like to ask a question in terms of maybe the ratio between plastic specialists, plastic surgery specialists, and also like people in general in Malaysia.
Okay, I think if you follow the WHO guideline, one plastic surgeon should represent about 800 to 1,000 per population. So in Malaysia, we have, I think it's less than 150 plastic surgeon, which half of it doing only cosmetic surgery. So leaving about 60 plastic surgeon managing about 30,000, 30 million plus of Malaysia population, still in a lot of deficiency. And if you want to see the numbers of reconstructive microsurgeon in Malaysia, I think you can count with your number of your digit in your hand, both hand is less than that. So there's a lot of prospect in plastic surgery, but once you embark into a reconstructive surgery, you are talking about a lot. It will take a lot of your time, your personal time, your family time, and it need a lot of dedication. Because if you see some of the surgery that I show you, they are mostly last about 8 to 12 hours, and some can go on to more than to up to 24 hours. There are a few that last more than 24 hours. The longest I involve is about 72 hours. So that's maybe one in the blue moon you encounter cases like that. But don't worry, you still got time to eat. You have your toilet break, but you need to plan properly. But sleep may be difficult if you're working alone, but if you're working in a team, you can have multiple team people to do at a different time. Then you may have time to sleep or take a rest in between the session that you'll be involved.
All right, so you could say what would be required of people who are interested in taking plastic surgery is capability to tahan jam yang lama dalam surgery, teamwork, obviously, right? What else? What else would you say?
I think you need a stamina also.
Oh,
And
stamina.
yeah, good stamina and perseverance, because the surgery sometimes is not hard, but it's tedious. It's not a major for the patient. It doesn't. It's not a what do you call it? A so-called high pressure to the patient heart or physics, but it's kind of more on technical, meticulous and detail into
Oh.
the reconstruction. Such as, when you do tissue transfer, some maybe you can see the blood vessel very well, some maybe the blood vessels only 1 or 2 millimeters diameter, which is very small. So you need a very meticulous technique. Sometimes it takes time because you cannot rush into it, because if you rush into your surgery, you may damage the small blood vessel, and all the surgery what have you done need to be redo again, and probably take from another part of the body to be transferred. And after the surgery, it's not end there. You need to monitor. Okay.
Yeah.
So you need to make sure the patency of the blood supply that you connected, and this normally lasts minimum of 5 days, and to go on till 2 weeks or 3 weeks before it fully stabilizes. So until 3 weeks, you can still lose the tissue that you transfer via the microsurgical technique. Okay?
Wow, interesting. Okay, so we have questions. So from Hawa, she asked, Sir, kalau tak buat skin crafting tu, kalau kita terus jahit macam mana? Macam tarik terus kulit tu ke?
Yes. Okay. If there's a tissue laxity, yes, you can. But there's a place where you don't have a tissue laxity, or the defect is too big. How much you pull, the tissue won't come, the skin won't come together. Then you need a skin grafting. And also the area where you probably can pull, like in the elbow, right? If you see the elbow, you have the defect here in your elbow. You can bend like this, you can stitch here to here, but you won't be able to stretch your elbow back. So that won't be any good if you do that. Okay.
All right. If Hawa has any more continuing questions, please do ask. Okay, so from Arif Aiman, he asked, Doctor, kenapa doktor pilih untuk further study into specialist instead become the normal doctor? The doctor that doesn't specialize, I guess.
Yeah, okay. I think everybody want to become a special, isn't it? So you have your own niche area. So in why I choose plastic surgery, I think I kind of told you earlier when I was in the medical school. So you have to do a lot of rotation. So you do a lot of things, bit and pieces, for a short time. So you can have exposed to the disease or condition in that specialties, and also to give you experience and then give you option to open up your eyes, what you want to do next. Okay. So for me, when I do see the reconstructive plastic surgeon perform their operation, I feel what they call that, very interested. You feel excited to see how they gonna close or reconstruct back the defect that the patient has. So that's how I got interested, especially the reconstructive microsurgery, because at that time the only place that do reconstructive microsurgery in Ireland was in that hospital. So there's about 6 surgeons having the similar specialties. So they are working very well together, and you can see there's a lot of good result. I can show you more photos, but you can reconstruct a lot of things, from mandible, jaw. You can reconstruct the nose, as you can see. You can reconstruct the ear. You can reconstruct the limb, chest, even the perineum, basically head to toes. Yeah.
All right. So in plastic surgery, you cover everything. You
Yeah,
cover
cover
or do
everything.
everything. All
So if
right.
you want to become a plastic surgeon, you better know your anatomy well, from head to toes, not just a certain region. Like for example, ENT, they only know the head and neck region. For orthopedic, the limbs, the upper limbs and lower limbs. The obs and gynae, the private part of the female, the uterus, the lower abdomen, for general surgery, abdomen mainly, the bowels, cardiothoracic, the chest. Yeah. But plastic surgeon, you need to know everything, because you need to be able to take tissue from every part of the body, and it can to be as an option to be transferred to the uh, to the to the defective part lah.
Ah, faham.
Okay.
All right. Okay, so if Arif Aiman has, more questions, if you are interested in becoming a plastic surgeon, maybe you can go itself to the um, Professor Arman's social media, or if you can ask here, also do please ask. But actually, when you say like it covers, like plastic surgery covers from head to toe, um, if say you weren't good at anatomy, but you're still interested, would you give it a go? Like, would you suggest that student to give it a go?
Yes, why not? But you need to put an effort to be good at anatomy. If you want to become a surgeon, basically it's a must to have a good anatomical knowledge, because you want to cut somebody, you need to know what are you cutting, what the structure that you can cut, what the structure you cannot cut. If you don't know your anatomy, you may be cutting a vital structure that is important to the patient. If you don't know the anatomy, you may be afraid to cut anything that you're supposed to cut to make the surgery faster. Some structure are redundant or not so important, not so vital. So when you do surgery, sometimes you need access. You mean a route to reach the target organ or target area. But if you are not sure this thing can be cut or not cut, can cut or not cut, then you are wasting time.
Ah, yes, time is
So
very precious.
yeah.
All right. Okay, so next question from Ibrahim, Baim, who is also part of ANSARA. Berdasarkan pengalaman doktor, apakah perkara yang paling mencabar sebagai seorang plastic surgeon?
Okay, I think the challenging part, I think I will talk to with my perspective as a reconstructive microsurgery. So the most challenging part is when you have what they call it, a not so perfect blood vessel to use as your reconstruction. For example, if the patient has a trauma or accident, sometimes the tissue already smashed or crushed, and the blood supply is not so perfect, but you need a good blood supply to reconnect to your transferred tissue for reconstruction. Sometimes you need to do a bypass graft, you need to do additional work, and then afterward you need to make sure the tissue are well perfused. So if not, your reconstruction will be gone to waste. Okay, so that is the most important thing.
All right. So if Baim has any continuing questions from that, do ask. All right, so from Moon Hanim, doctor, what are the consequences to the surgeon when we failed to do the surgery? Oh,
Okay, I think I probably need to become more specific in terms of your question. Fail meaning we cannot do the surgery, or we do the surgery and we have failure fail to get the result. Okay, so well, if you are covering a vital structure, for example, okay, I'll give an example of a cancer in the head area, in the scalp. For example,
Oh,
when you
scalp.
remove
Okay.
that, you need to remove, let's say it's involved the skull, the bone. When you remove the bone, you remove the scalp, what you can see is the brain. So when you see the brain, you need to cover the brain, because the brain, if the cat get infected, you can get meningitis and it's going to be fatal consequences. So, and then it also, if you don't close it, it exposes it to trauma. You know, people can easily pick your brain. Yeah. So you need something, a protective layer. So in that case, if you fail, meaning you may need to redo your reconstruction. Okay, let's say you take for example, you take skin from thigh or from abdomen, from tummy, you cover it and then it's failed, then you need to perform another surgery. Yeah, remove the whatever the failing part, the dead part of the tissue that you have transferred because it's not perfusing, no blood supply because the blood supply may be blocked or maybe get infected or whatever, and then you lost the tissue and then you just need to redo it.
All right.
Okay.
I hope that answers your question, Munhanim. If you have like further questions from what Dr. Arman has explained, do ask. All right, so from Cikgu Aisyah, she's the counselor of MRSM Taiping. Ada tak case or injuries yang plastic surgery pun tak boleh nak pulihkan? I think mesti ada kan?
Yeah, I'm not sure there is.
Case yang macam mana
okay.
tu?
For example, okay, I think most defect can be closed, but there are defects that we probably choose not to close or to reconstruct, maybe because of the patient factor. For example, the operation is usually, if for major or complex reconstruction, it will take hours. And then long surgery may not be suitable in certain condition or patient with premorbid or comorbidities such as heart disease. I think the heart cannot cope with long prolonged anesthesia, which they may not survive. So in that case, we may not offer reconstruction. So basically nowadays, almost all defect can be covered. Just how much you want to spend, how much you want to do. For me, what will be limiting, one, as I said before, is the precondition, premorbid condition. I mean, patient general condition, such as if they have a heart problem, the heart is not functioning at its full, or maybe just less than 40% of its capacity. So when you do echo as a pre-operative investigation, you can see the heart condition is not good, then maybe it's not an option for the patient. We may need to think another option, which can be a alternative, but maybe a longer, may take a longer time. Normally, our body designed to heal itself, just no matter how we do it and how good result we want to get it. And then another way, and another reason why I may not reconstruct is maybe in the condition patient have a severely diseased vessel. So you don't have the place to plug in the tissue that you have you want to bring. Let's say patient have a problem in the ankle, okay, and the patient have a vascular disease of the limb. Even the limb itself, without the injuries, is a threat to the patient, as a threat to be amputated. Like you can see a lot of patients in the diabetic foot has amputation because of they have diabetic foot infection secondary to poor blood supply. So sometimes the blood supply cannot be restored to a what they call desired amount to give a perfusion to the tissue. So as a microsurgeon, reconstructive microsurgeon, I need somewhere to plug in the tissue that I have dissected from one place to the other. So in that case, maybe the option will be limited for the patient.
All right, thank you. I think that covers it very detailed. All right, so from Ibrahim again, dari segi tangga gaji seorang plastic surgeon, bagaimana doktor?
Okay, it depends where you work, which country you're working. The salary will be different. Okay. In Malaysia, generally, if you're working in the government hospital, when you start become a what do you call that, the specialist, normally you will get around you have basic salary and you have allowances. So normally with allowances, specialists should get around I think around 10k, 10,000 ringgit a month minimum. And then it depends how you do, how many on call you do a month. That will increase your salary also, because if you do less on call, your on call allowances will be lower. But if you do more on call, your on call allowances will be higher. Okay, and as you go on, you climb your grades throughout the years. If you reach the highest, normally it's about 25,000 a month you can get, and then your basic salary will become about 13-14,000. Yeah. But if you go to Jusa or Tarif, Toulouse, maybe if you get into the administrative work position, you may get higher basics and allowances. But if you go to private, depend on what you do. If you are a reconstructive surgeon like me, maybe your salary range depend on number of your patient. If you want to treat more patient, you want to work harder, you can get more. So basically, for one reconstruction, complex reconstruction, a patient, normally you have to look after the patient for 3 to 4 weeks in the hospital. It's a lot of work. You have to see them every day. Sometimes you have to do dressing every day, not just every day, sometimes twice a day. One hospital stay for 3 to 4 weeks, you may get around 20,000 for one patient. But if you get 3 or 4 patient, complex patient, you may get more. Okay, that's roughly. Okay, for your simple cases, you may get few hundreds to a few thousand each cases. So basically, it's depend on the cases that you do. If you choose to do not to do so much, just enough, enjoy your life, you can do so. But some doctors, if you want to chase for the money, you have to do more cases. But when you do more cases, you get tired, and then you prone to do more mistake, as you do your work. So you need check and balance. I think money is not everything. If you have money, you have no time to spend it, there's no use for you also. Okay. And if you are doing a lot of cosmetic surgery actually, the fees for the private doctors are not regulated. You can discuss with your patient how much you want to charge. If you are what do you call that, popular doctor, high demand, you can just say what you want, how much your fees, the patient agree, you can go ahead and do it. But for non-cosmetic surgery, there is what do you call that, act that control the fees. You can only charge according to the fees schedule. You cannot charge extra. So whatever you do, you can charge a maximum with the schedule, but you can always charge less. Normally, the schedule will give a ceiling amount of fees that you can charge. So plastic surgeon doing cosmetic, I think they can easily earn more than 100,000 to 200,000 a month. And the popular one, they can earn up to 1 million a month. Okay, but if you don't do cosmetic, like me, I rarely do cosmetic surgery. I pick cases that I think is worthwhile doing, and then that will give a good result to the patient. Then I'll do. If not, I leave cosmetic surgery to somebody else. And reconstructive, I think you can see it's rewarding in terms of you can see the patient return back to normal, give them functionality, give them their appearance, such as you can see the cleft lip and palate patient. After the surgery, they look more normal than the split lip or palate. They can talk better. They have like swallowing better. The food doesn't go to their nose, through the defect, and etc.
Right, thank you very much. So if people are trying to decide whether cosmetic surgery or reconstructive surgery or any other surgery, I think they can discern the differences in what they are trying to seek. Of course, like you said, money doesn't really always become a priority, right? I mean, at the end of the day, sometimes the things that make you happy are very internal, Ken.
And money is never enough anyhow, I have a
Yes.
colleague who earn 1 million a month, and seems like he's looking for more. 1 million
Oh,
a month, so
wow.
not already. But
Okay.
he always say that's not enough. So
Oh,
how much is enough? So that's individually, you have to decide individually.
yes, true. Oh, but I do have a question. I mean, I understand like uh it's natural for doctors to deal with death. So,
Yeah.
how do you like, because most of our audience are maybe people who are still trying to figure out whether to specialize in what or even take medicine. What would be your advice to these people who may be afraid of facing their first patient death?
Well, I think life and death is not in your hand. You only help. Okay, when I do surgery, I also tell my patient there's no 100% guarantee. You will get what you want, and you will get what I plan to do. Okay, because you can only do the result is, I think, if a Muslim, I think it's easy. I say it's up to Allah to decide. You only you only a medium to provide them with the treatment, and the result is all in Allah's hand. And if anybody want 100% guarantee from me, I say, okay, it's not me. You can find somebody else who can give you guarantee.
All right, thank you so
So
much.
life and death, you can gauge with the type of surgery. As you can see, if you do extensive surgery, death is always a risk. You need to explain to the patient. Best if you involve their family or their immediate family to be involved in the discussion. So it's sometimes hard to say. When you do surgery, you may die, but things that you need to disclose to the patient. If not, they come back and hunt you and blame you. So
All right.
okay.
Actually, we have exceeded our time, but may I ask, do you have like anything going on like right now or in a few more minutes, Dr. Arman?
No, I'm ready to go home.
Ready to go. Okay, okay. Okay. I think we'll stop the questions coming in. So I'll just finish off the questions. So
Okay.
we have 6 new questions. And there are a few comments on Facebook for Dr. Arman. So later I'll send it to you, or you can go to the page itself. But I think I'll just send to you lah.
Yeah, I think because I think the last few days, or maybe I only have a glance at my own Facebook. So sometimes if
Itulah.
people PM me or ask me question, please don't feel what they call it, disheartened if I don't reply immediately. Even my WhatsApp that is always close to me in my phone. Sometimes I have a backlog of messages to answer, because like especially the last few days it was quite busy. Last time I finished at 2 a.m. in the morning, and today I have a unscheduled operation that I have to do on a few patients that come see me in the morning. And hopefully tomorrow I can have a good rest, and the next week will be another busy week for me. There's a few major reconstruction ahead.
Hopefully, more rest for you. All right. So from Hawa, kalau face implant surgery tu macam mana apa contoh case dia? I think it was covered right just now.
Face implant, maybe you are talking about nose implant, cheek implant, or chin implant. Yeah. There's a few options. You can have autologous or foreign bodies, foreign material, such as a silicone. You have silicone, they come in many, what do you call it, form. They have a gel form, they have a solid form. So you can carve the implant according to the shape that the patient wants, or there is a pre-formed implant with multiple different sizes that you can pick and choose for the implant. Okay, I normally prefer a autologous, meaning from patient own body. So if like a nose reconstruction, like the picture that the patient that I show you, it was carved from patient own rib cartilages. Yep.
All right. I hope that answers Hawa. All right. So from Cikgu Aisyah, ada tak skin atau tissue from specific area yang preferably used during skin grafting?
Okay, it depends where you want to place it. Like if in the face, our face is exposed to the sun. Okay, we want to find a skin that from the sun exposed areas such as around the face also, or in the neck or clavicle area where it has a sun exposure. So because the color will be the same like in the face. Okay, like if you other places, okay, the type of skin graft also different. They have a full thickness skin, full thickness skin graft or split thickness skin graft. Split thickness skin graft is where you take only partial thickness of the skin. And normally this one you use a device like a dermatome or machine, or manually using a flat knife. Okay, a full thickness skin graft, you excise the whole thickness of the skin like that, and you need to stitch back to close the skin donor site that you take. Okay, in the face area that you can normally take is behind the ear, where you can hide the scar, or if you want a thinner skin, like you want to reconstruct the eyelid, you can take from the opposite eyelid. Okay, or you can take from the area in the in the neck or in the clavicle, yeah, to cover the defect in the face, because it gives you a more matching color. Okay, if you need a bigger skin graft, normally you take a split thickness skin graft. It won't be as best aesthetic outcome as the full thickness skin graft, but it gives you a large area of skin to cover. Normally this one you take from the thigh, you can take from the buttocks, or you can take from the scalp. Okay, if you take from the scalp, after the hair regrow, you need to shave the hair, of course, when you take the skin. When you the hair regrow, you can hide the scar very well. But if you take from other places, okay, you will have a scar that can be seen.
Sorry, I didn't understand.
Siri, okay. All right. Hopefully everyone else understands. Okay, so Arif Ayman asked, Doctor, when become the plastic surgeon, do you think it is possible to have work-life balance?
I think that's, again, as I say, is your choice. Okay, but when you work in in the government hospital, normally you are quite busy, because, as I said, the reconstructive plastic surgeon number is very limited. Okay, in the government hospital, those that doing reconstructive microsurgery, I think you can count with your hands. You know, you don't need your toes to add the numbers. Yeah? So if you have a lot of cases, then you become busy. Sometimes it's periodical. You cannot expect to get the case but when they come, you just have to deal with it. And if you work in private, I think again, you have more control of your life. You can pick and choose the cases that you want to do. You can pick to be busy, or you can pick to be relaxed. You know, money, you can tailor what you want every month. Okay, if you want more cases, you want more money, you do more cases. Okay, but you do more cases, you get more tired, you have less time. If you have more time, you do less work and you have more time. And the more you earn, the more tax you pay. So sometimes you think, you see the number of amount of taxes you paid, say, oh my God, is it worth it? You know, maybe you work less, enjoy your life, because sometimes you have enough money, excess money, but you have no time to spend. And if you die, somebody else will spend your money. So might as well just get enough, enjoy your life.
A lot of life quotes to live by, actually. But actually, since you say that, like, there seems to be a lot of perks when you're in private compared to public. So you could also say that it is a lot more difficult to enter private lah kan, compared to. All right.
But if you like what I'm doing now is a very niche area. I think in Klang Valley in private, I think I can say I go to almost all private hospital to do reconstructive microsurgery. Okay, because not many people are doing it, but in government, you can have it in HKL, and in UKM, they are coming soon because they are my apprentice. So hopefully in a couple of years' time, I can relax and not doing so many cases in UKM anymore, because I got somebody to take care of the cases over there. Okay.
Yes, hopefully. All right, so another question from Hawa. Sir, kenapa kalau skin burn tu kena gantikan dengan kulit tilapia? Ooh.
Okay, like I think I didn't say, I didn't give example of kulit tilapia. Kulit tilapia, I think, or what we call that, xenograft. Xenograft is xeno is from things from animal, graft, yeah, tissue from animal. Normally, like the allograft that I showed to you, skin bank. Normally, the skin bank that we have here either is harvested from. In Malaysia, I think mostly from living patient, and we have a skin bank that is imported from European country, meaning whoever had that got kulit mak saleh lah. So, but that skin is only temporary. Okay, before your own skin grow underneath and expel the allograft or the xenograft. If it takes longer, you may need to replace it again. Normally, the skin graft that not from your own body will be rejected after 2 to 3 weeks time. So if your skin injury is deeper, you may need longer time for the skin, your own skin, to regenerate. Okay, and people do skin graft because if it's involved a larger area, you loss of your skin protections that provided to your body, such as it protect your temperature, protect you from losing your body fluid, protect you from microorganism or bacteria by forming a mechanical barrier. Yeah. So there's a lot of skin function that is lost when there is a large burn area or injuries where you lose your skin. Okay, I hope that answered.
Yes.
I personally haven't used tilapia skin or fish skin, but used the allograft that we process it ourselves from a living donor. Living donor meaning they had surgery that needed their excess skin to be removed, and if in that the case, I normally ask them whether we can have the skin rather than throw it into the bin. We have it, process it, and once it's matured and ready, can be reused in another patient that's more needy.
See, even in medicine, you reuse.
Yep.
All right, so from Moon Hanim, doctor, if the replaced tissue shows the rejection signs, what are the other options to replace them, especially in the case the patient is skinny and the rejected tissue originated from the family?
Okay, like I say, if you take skin from another person, normally if a same species, we call it allograft. Okay, if you take it from patient own body, we say auto, meaning their own body tissue, and it's from different species, it will be a xeno. Okay, so if you're taking from a different person in the family, if it's not an identical twin, so which is they have a different antigen in their cell surface, the tissue will be most likely rejected. Okay, normally this skin graft or whatever is used as a temporary measure only. So normally it will need patient own skin or waiting for the skin to regenerate itself and heal the wound. Okay, if the patient has a large injury area such as in the burn, so normally what we can do, there is technology now, we can take the skin and culture it in the lab. Okay, so you can have a sheet skin graft that is made in the lab or bioengineered, or we can have a single cell skin that can be sprayed into the wound, and once it sticks, it will duplicate and regenerate over the wound. So there's a few new things that that we are doing now in Malaysia. Okay, there's a few labs in the government sites. I think in USM we have one skin lab, and in UKM also we have one, which is quite advanced at this stage.
Right, thank you so much. I hope that answers your question, Munhanim. All right, so now it's 10:30. Thank you so much, Dr. Arman, for spending 30 more minutes with us. And thank you everyone for participating in the session tonight. Those who are watching from live FB and also those who are in Zoom itself. Okay, so thank you very much, Dr. Arman, for being here tonight, giving us your knowledge, sharing us your passion. I can see your passion very much. All right, so I think.
All right, thank you very much, all.
Thank you, Dr. Arman.
Yes.
Terima kasih, Dr. Arman. Thank you, students.
Oh, yes. So because the SPM MRSM is near, SPM is very near, right, Cikgu?
Yes.
So we wish you all the best for your SPM, for your trial, and also for your SPM. Please study. Do not have too much fun. Wait. I would suggest you wait. I know it's been delayed many times, but have perseverance. It will end very soon. So all the best.
Okay, all the best to all. Thank you. Assalamualaikum.
Waalaikumsalam. Thank you. It's okay.
Bye.